because it sits here and gives me a little loading bar. It's very cute. All right. All right, guys, perfect. We're live. And yes, the little video is showing up. So now if anybody starts joining our sessions, they'll start to hear us all chatting.
And we do brief personal introductions before the presentation. Is that correct?
I mean, I've honestly taken the tact that I just sort of introduce both of you as speakers, and then you're welcome to, you know, give your own little intros that you think would be good.
I think that's right.
Perfect.
Hossein, would you be willing to, you know, introduce yourself and a little bit about the team and Sarah's new position, and then I can take it into the presentation, or do you think it's?
I think let's just keep it the intro that you can do for us, and then we just go into it.
Okay, great.
And now we just get to sit here a little bit awkwardly while we wait for people to join our session.
But do you actually get to see how many people are joining?
I do. It might even be something you can technically see. I'm honestly not entirely sure. It won't show until I think we hit 2 p.m., but my last one gave me a little so many attendees button, so.
Okay.
All right, guys. It is now 2. We've got about 15 attendees joining us, so I think it's a good time to go ahead and get started. So welcome everybody who's joined us. My name's Rachel. I'm just a session facilitator. I'm not the star of the show, but I wanted to let you know a couple of things. Please, if you have any questions, go ahead and use the question and answer tab in the event portal to ask them. We'll collect them the entire presentation. There'll be time for some answers at the end. Please save the chat for general chatty things, but putting the questions and question and answers helps us keep track of them. And with that, I think we'll go ahead and get started. So I'm going to turn this over to Hossein and Robert.
Thank you very much. My name is Rob Schechtman, and I'm here with my colleague Hossein Soleimani, who is our Chief Data Scientist. I am the project manager in the Health Informatics Data Science and Innovations team at UCSF Health. We're a group of about 10 people, including 6 data scientists who work on artificial intelligence, data analytics, and data visualization within the health system. And we're here to talk today about our journey of evaluating AI and specifically for trustworthiness as a part of our new governance process. So we'll start with how much AI we found when we started looking around and some of the concerns that led us to realize we needed to stand up a governance process. We'll talk about the frameworks and principles that we chose and the governing structures that we put in place. And then we'll share a couple of lessons learned based on some of the applications that we've already put through the process. Not only lessons learned for AI governance in general, but also for UC-wide collaboration across the health systems in our UC system. So, sorry about that. So first thing we'd like to say is that while there's a lot of interest in AI as the wave of the future, it's already here. And we first started working with AI models from our EHR vendor Epic in 2017. We piloted the risk of no-show for clinics. We went live system-wide in 2018. That same year, we implemented our first locally developed predictive model in the electronic health record. After that, we spent about 3 years evaluating several predictive models. The radiology informatics lab opened in 2020, doing a lot of work with embedded AI in that rapidly developing space. In 2021, we rolled out HiPAC, which is a locally developed high-performance AI cloud platform within the UCSF network based upon AWS HIPAA compliance, gives our researchers and our clinicians a space to develop, test, and deploy homegrown AI tightly integrated with our EHR. Last year, our capacity management center went live, and with that came several AI models, and we kicked off our first full inventory of AI tools across the health system. And this year, we launched our AI governance. We also kicked off several demonstration projects for homegrown AI integrating with the EHR. And things are evolving very rapidly. Just a few weeks ago, ChatGPT and generative AI arrived for our researchers. So things are moving quickly. Last summer, we received a letter that we know went to most health systems across the state from the Attorney General asking us to inventory AI systems and describe what processes we had put in place to evaluate them and to monitor them for bias. And when we started looking around at IT security reviews over about 7 years, we were really surprised to find a lot more AI than we knew about. We found it in pharmacy, we found it in facilities management, we found it in the EHR with models that we knew about, but also with prescription coupons and a pilot for automated AI scribes to to translate and create a clinical note out of a clinical visit. There were literally dozens of AI applications that had gone through IT security review. And we were surprised because we didn't know which of those had actually gone live. We didn't know specifically how they were evaluated, and we certainly were not monitoring most of them on an ongoing basis. So we needed to act quickly. Part of that was developing a process to flag any systems, software or embedded systems that may have AI during both the IT security review process and the contracting process, but also to start standardizing and spreading out methods for evaluating and implementing AI. Part of that is also developing a central inventory of AI tools and use cases as part of our enterprise data warehouse. And this was luckily leveraging efforts which were well underway already. The informatics team had been aware of the need for a very careful review of AI design and performance based upon our experience with early AI models in the EHR. And we also realized that we needed some standard frameworks to describe conditions of AI acceptability. Each application was basically treated as a one-off standing use case, and we needed to create some standards for the entire organization. So Hossein is going to talk about some of the issues that led to our realization for the need for review and monitoring of AI.
Thanks, Rob. So let's, for a moment, take a step back, and I want to talk a little bit about what is special about AI and why do we say that we need to carefully review and monitor it. I think there's some animation, Rob, if you want to hit one more. Thank you. So certainly when you think about non-AI devices, like your typical like physical devices, IT devices, or even medical devices, take, for example, a printer. It will work the same regardless of whether we use it at a clinic at UCSF or a lab or a classroom in Berkeley. It just prints out what you have, what you see on the screen. It's more or less the same. But what's different about AI is that depending on where you use it, patient or provider population that is being the tool is being used for, what kind of workflows you have and interventions, the system may perform very differently. Either perform a lot worse for everyone, or the performance varies by depending on what type of population you're working on. And this could create potential bias issues or just unreliability. And that's why it's very important to evaluate this tool on your data. And because all these different factors may change, it's also important to keep monitoring the performance of this tool after you implement it. So I want to give you a few examples, real examples based on our experience and hearing from other health systems across the country. One example is a few years ago, we evaluated a vendor's tool that was designed to predict how long a patient is going to stay in a hospital. While the marketing material were somewhat reasonable, when we looked at this tool on our data, we did a little fun experiment of looking at it, looking at how it performs compared to if we just roll a pair of dice. And we saw that for most of our patients, actually rolling a pair of dice would perform better. So this is an example where just going from somewhere where the health system that vendor developed that tool to our data, the performance could change quite significantly. Another example that came out of a hospital in Michigan is when COVID hit, they started to see the tool that they were using for flagging who is at risk of sepsis, a type of infection in the hospital. The tool started to have a lot more false alerts. And this is just because now you're seeing different types of patients that we did not see before. Another example is when you think about different tools that people use for seeing which patients are at high risk of no showing for their clinic appointments. We had tools that were built based on pre-pandemic data, where most of the visits were in person. Now, if you think about in-person versus telehealth visits, whether you show up or miss your appointment, the risk factors could be very different depending on whether the visit is in person or video visit. So those tools may not work actually well after pandemic, now that we have a lot more telehealth visits. And lastly, it's not always about performance metrics, it's about utility of that tool for your use case, and what does that performance metric mean exactly for your end users. Another example we have seen is there was a vendor sepsis prediction tool that used vancomycin order, a type of antibiotic, as a predictor, as an input in the tool. That artificially helped increase the performance metric, but when you think about the utility of that tool, when providers already ordered antibiotics, there's not a lot of point in flagging an infection risk. If you go to the next slide, Rob, I think so. When we think about all these issues, the need for evaluation, what's critical also to think about bias and how these performances could vary for different subpopulations that we have. This is where we say that the tool may be biased. There are a lot of examples of this have been in the news recently, and you might have heard about them. One example that we are highlighting here is about an algorithm, a special type of algorithm called automatic speech recognition. This is a tool that is used in system devices like Siri, Google Assistant, and also in a clinic setting where we could have AI scribe tools that listen in the background to the conversation between a patient and provider in a clinic visit, and then produce some kind of a summary of that visit. So it's been documented in this paper we are highlighting here is that the performance, the error rate of these algorithms could vary a lot by speaker's first language, race, ethnicity, gender, age, and so on. And this has implications if we wanted to use such a tool in our clinics where we have diverse population, different types of patients, providers. The performance of this tool could vary, and how do we think about evaluating it and monitoring it?
So the Attorney General's letter last year really made us aware that we need to be more systematic about looking for bias and also accommodating patient populations or provider populations who may be affected by bias. We looked around for broad frameworks or metrics for AI trustworthiness. And in 2019, the European Union was the first to publish such a framework. We ended up going with two frameworks, one from the US Department of Health and Human Services, which came out 2 years ago, called Trustworthy AI. And we supplement that with the recommendations from the UC Office of the President, which were published last year, the recommendations guiding the use of AI in the UC system. The UCOP recommendations fall under 8 general categories, and you'll see in a moment there's a fair amount of overlap with the HHS, Trustworthy AI. A few of the categories such as appropriateness, human values, and shared benefit and prosperity, we're looking to apply more in the discovery and vetting phase than in the AI governance and evaluation phase. The HHS principles were useful to us not only because they were focused very specifically on healthcare applications, but they also provided some detailed guidelines on how to implement these in use cases. So there are 6 different principles, and Hossein, would you like to address these? how we use them.
Maybe we can get to it when in the later slides now.
So in the fall of last year, we chartered our Health AI Governance Committee for the health system, which is designed to direct the oversight and evaluation process for any AI tools, whether developed by UCSF researchers or acquired by UCSF for use in patient care delivery and in the health system. Really, this was, as I mentioned, our attempt to standardize the way that tools are tested and evaluated using this framework for trustworthiness from the Department of Health and Human Services. We're also using this committee to facilitate linkages among researchers and clinicians. There's a huge growing interest in the use of AI and machine learning technology with pockets of expertise. And this committee serves as a forum to bring people together and to share best practices, both for evaluation and for implementation. There are 15 members on the committee from a dozen different groups across the health system and faculty research, including representatives from health equity, from ethics, from human research protection, and our compliance and legal departments, as well as clinical and operational leaders.
So,
go ahead.
Sorry. So I guess here we can talk about a little bit how we took those principles that are somewhat abstract and made them into concrete checklists and questions for each phase. We started by mapping out the entire life cycle of an AI tool from discovery all the way to implementation. And we came up with concrete items, questions that could apply to each phase. So in the discovery phase is where we do impact versus complexity assessment. What is the problem you're trying to solve and how do we think about evaluating it? And then we have the development phase where we either buy or develop the tool and evaluate it on historical data. And then we go to actually implement the tool and evaluate it in real time without displaying the output to the end users. This is what we call a silent study or perspective evaluation. And if the performance is good, is what we expect, then we do a small pilot or a trial, and then potentially a deployment where we go into an ongoing stage of monitoring and maintenance. So we took each one of these steps and we started to think about how do those principles apply? What do the developers need to do? What do the stakeholders need to do? And we have concrete checkpoints for people to come to the committee and present their findings of that phase, and the committee would approve going to the next stage. We move to the next slide, Rob. So take, for example, the retrospective review. This is where we have a tool and we want to evaluate it on historical data. We start by bringing some of the content from the discovery phase, and we asked, so what is the problem this tool is designed to address? Why do we even need an AI? A lot of the time, technology or AI may not even be the answer. And what do you expect the users to do based on this tool? And then we go to the trustworthy AI principles. So we take robustness and reliability. This is where we think about, is this tool robust or reliable to be used? How do we think about performance metrics? What do we look for to measure reliability of this tool? And what's an acceptable level of performance? What are the consequences of different types of error? that will help us determine how we define metrics and how we set the threshold. And then we look at, do we see that performance in the historical data? Next, we go to thinking about fairness bias. First, we start by asking, how do we even define fairness in this use case? It's not always the same, depending on what's the intervention, what's the problem, what the tool is. There are different metrics that we provide that could apply for thinking about fairness. And we say, what is an acceptable threshold to call it a system fair? And again, do we see that in the historical data? For transparency, we think about, what do the users actually need to see, to have, to be able to trust this tool and to take action based on the output of this tool? Do we have any mechanism for them to give feedback and so on? And then the other principle on the next slide is about responsible and accountable. So we think about, is it possible, if something happens, to go back and see how the AI tool arrived at a certain decision or output? Who would be responsible for monitoring and maintenance? And how do we document and how do we record intermediate decisions? So this is just an example of, like, for one of those steps of the process, how do we apply those principles? The committee started taking and reviewing use cases starting from March of this year, and we wanted to spend some time and go through some of the issues we have seen and lessons learned, and potentially identifying some areas where we could collaborate with other campuses across UC. One of the interesting things that we have observed is that no one actually disagreed with these principles. Everyone we talk with, they say, great, these are the right things to think about, these are important. But what happens in reality is that what we see is a large variability in developers' actually skill set to be able to do all these analysis that we're asking them to do. We work with a wide range of people, including health system data scientists, people from research community, including students, fellows, researchers, faculty, and also vendors. And while everyone can do the standard out-of-the-box performance metrics or things that would go with building a model, not everyone can think about what's the right fairness metric, how do we compute them, and how do we set an operating point depending based on what we have, what the workflows that we have. And say a model is biased, or there is fairness issue, how do we fix it? How do we debias it? So these are the things that we see that not everyone is able or has the skill set to do. And one of the lessons that we're learning is that it's not all just enough to have the governance process and the committee and processes to lay out these requirements. We actually need to have resources to help people, to guide people through, to take their application through this process. And when we say resources, this could be dedicated data scientists that work for the committee and could help different groups that bring their applications to the health system for implementation. And or it could be like some kind of accessible training material that could help wide range of people and teach them how to think about these things. Currently, the situation that we have is that all the members in our committee are basically volunteers with their full-time job, and they spend part of their time on reviewing cases. Another interesting thing that we see is in reviewing vendor tools. And this is where, especially, we have a lot of tools that we call embedded AI tools. These are when we have a tool that's AI is part of it, but It's not the entire picture. An example we talked about earlier is AI Scribe. This is a tool that listens in the background to the conversation between the provider and patient in a clinic visit and generates a note in a particular format. So when you think about this system, there are many different aspects to it. There is a voice to text model, a speech recognition system where it first just transcribes what was said. And then there is a language model that on top of that takes that output, takes that text and produces a summary of it and turns it into a particular format. So there are a lot of different pieces to it. And it's not always easy to think about how do we measure the performance of this tool on a large scale. What makes it even more challenging is that these tools are often built by external vendors where we don't have good visibility into all the details of the tool. And while it may be in their interest to paint a very nice picture in their marketing materials, we have not seen a lot of vendors that actually think or provide data around the performance for across diverse populations. And this is an area where we see challenges in evaluating those tools. And this is one of the areas where we're going to talk about in the future slide also, that this could be an area where we could collaborate across UC campuses to include terms in the contracts. So we have more leverage in or access to some of the data that we need for evaluating these tools. Quick summary of what we discussed, and then I want to end at what lessons we learned and what are the next steps and how we can work with other UC campuses to improve this process for everyone. We talked about AI is actually already here. It's in a lot more tools than one might realize. And we talked about, because of the nature of these tools, we need to have rigorous processes for evaluating these tools before implementation, and think about also monitoring them after a tool is implemented. And we talked about the HHS guidelines that we adopted and took them and converted into concrete checklists that we could apply for at different stages of life cycle of an AI tool. When we think about the lessons that we learned and opportunities for collaboration across UCs, one of the things that we can think of is it would be nice, and it probably makes it easier for developers and vendors to have, if we have consistent criteria across UC campuses, especially across UC health campuses, to how we think about evaluating trustworthiness of AI tools. And this could be an area where we could collaborate. And also around training material on these evolving AI issues, in particular around implementation considerations for health systems. These training material could be for developers, vendors, researchers when they want to think about implementing their tool in health systems, and how should they think about trustworthiness, bias, and so on. But it could also I think there's room for having this training material or a version of it for health system leaders and our clinicians and stakeholders to also help them think about what are the factors we should think about when we want to adopt an AI tool. Rob, you want to talk about a few next items?
Certainly, we realized in terms of training that we already require HIPAA training and ethics training on an annual or biannual basis, and we've already approached our system leaders about adding to that some required training for AI issues. but also, as we mentioned, a huge area of opportunity and potentially the place to start are standard contracting terms, so that number one, all health systems know when AI is potentially coming in for a pilot or a use case, but also so that we have leverage across the UC campuses with these vendors for transparent data sharing and also for collaboration with them in the validation and monitoring of these tools. Even among the vendors, we have not heard any complaints about the notion of trustworthy or ethical AI, but when it comes to actually sharing data or working with us to look at both the training data sets and the test data sets, we need more leverage, and that can come across the UC system. And finally, the Attorney General's letter, while it was not legally binding, it did point to ongoing discussions in the legislature around regulating AI, trustworthiness, and bias. And we realized that in addition to standardizing the metrics and approaches to testing, there's huge opportunity for what is an acceptable mitigation strategy, either technical or operational, to account for the bias that is certain to be found across populations as diverse as we see in the state of California. So these are just some of the high-level opportunities for collaboration within the UC health systems and with the Office of the President. In our presentation, we did include, you'll be able to access this afterwards, both the UC Office of the President's definition of what is AI, because we certainly find when people are talking about AI, they may be referencing very different notions. Also, the Health and Human Services definition. We've included some of the performance metrics that, as Jose mentioned, developers and vendors are often citing, but some of the fairness metrics that they often have trouble coming up with. And we've included links to the various AI frameworks that we referenced. So thank you all very much. And at this point, we'd be happy to take questions.
All right, don't have any questions pending at the moment, but if any of you attending do have questions, feel free to ask them in that question and answer tab, and we'll get you a great answer.
I'd say we would also be interested in hearing if there are representatives from other UC health systems who are either working on or who have already stood up AI governance.
And you can feel free to use the chat if you'd like to type in on that. All right, I do have one question. I was asked if you guys could share that last slide again.
Absolutely.
Excellent, excellent. And if I understand correctly, and this is a big if, you all should be able to see the presentation under this session link because they have uploaded it for you. All right, we still have about 10 minutes to go, so please feel free to ask any questions if you have them, or pipe in chat if you have any experience with AI or AI in health yourself, as our presenters would love to hear that. The one thing I do want to let you all know is that there is a survey tab, and if you could take a moment to fill that out, that would be great. The feedback greatly influences how each new UC tech goes and the things that are added to improved, as well as I understand your presenters will get some feedback as well. Ooh, it looks like we've got a question. Anne's not from a health system, but at UC Berkeley, they have started a working group around the use of learning analytics. And so the presentation was very helpful in informing that.
Thank you. We certainly are seeing cross-disciplinary working groups sprouting up on our campus as well. And ideally, we could find a way to share that across the campuses, because at UCSF, for example, we've just started up a graduate program jointly with UC Berkeley on AI, and specifically AI in health. But there are just huge opportunities for researchers to collaborate across the UCs.
Not seeing any more. Oh, nope. The second I say that, see, that's why I do it. All right, we got another question. Can you give a couple more examples of hidden AI that you have encountered?
Well, certainly the most prevalent is probably in imaging and radiology. So there are, for several years, there have been very strong pushes in interpretation, in diagnostics, in various imaging modalities. And we referenced in the slide the imaging informatics group. You can Google that at UCSF. Very complex embedded AI. But even in our materials management systems, for example, in pharmacy stock levels, we were surprised to find not particularly complex, but certainly advertised AI algorithms for anticipating and balancing stock needs across multiple pharmacies. So an area where we had never even thought to look for AI. There's even a discussion ongoing right now in the UCSF emergency departments about a tool that is, in theory, integrating with our electronic health record to not only anticipate patient populations, basically capacity in the ED, but also staffing needs based on the anticipated complexity of cases. And that's another example where, as AI data scientists, we get a little concerned about the gaps between what might be claimed in marketing materials and what seems feasible based upon the data that we know is available. So there are three examples. Hussein, do you want to add anything?
Yeah, I would just add that this is just going to accelerate with the recent development in generative AI and large language models, where historically building these type of systems could take a data scientist or a team of data scientists, engineers, significant amount of time to build. With these new tools, it has become increasingly easier to come up with cool-looking demos and shiny tools. And it's even more important to be on the lookout for these tools and think about evaluating them.
All right, another questions with an apology if it was already talked about, but does UCSF build its own MLA models for diagnosis?
So in the health sphere, there is an ongoing discussion with the FDA about certification of AI as medical devices. And I know we participate in some meetings with the FDA on that. I believe we've seen UCLA and potentially other campuses present. There are some use cases that come either very close to or cross that boundary, in which case the FDA would need to test and certify them as medical devices. And when we talk specifically about diagnostics, that's one area where we have hesitated to go so far because of that FDA issue. Now, we certainly learned yesterday about groups at our own campus that were doing very innovative applications and uses of AI and generative AI. So there may be researchers who are working on that, but when you talk specifically about diagnostic tools, you have to consider the FDA regulations.
All right, we have only a couple of minutes left if anybody else has any questions to ask. And then I understand, I guess that's the end of UC Tech today. Everybody gets to go home. So for those of you joining us, again, if you have questions, we got, well, one more coming in. So is an algorithm for diagnosis considered an FDA tool?
There's a very specific set of criteria that the FDA uses, and I would point you to their website if you Google FDA certification of AI. I think there are 4 or 5 criteria, and a lot of that depends upon how that diagnosis will be used. If it's going to determine courses of treatment, then most likely it will fall under that rubric. But as with any government standard, it's probably best to involve your legal and compliance department. And actually, now that I think about it, there's another opportunity for cross-UC collaboration, because I am guessing that our legal and compliance folks are scrambling to keep up with this rapidly changing field as much as or more than even our data scientists. And the UC Office of the President certainly led the way 2 years ago with the working group.
All right, we do have another question. Do you have any examples of AI fails that help to convey the importance of these efforts?
I mean, certainly the examples that we talked about is the comparison with roll of dice, and been very helpful to make the case for need to look at these tools and evaluate them on our data. And there in literature also, there have been a lot of recent studies showing that these issues for many different algorithms, and certainly for bias, there are studies about speech recognition that we talked about. There are studies about some of the tools that insurance companies, for example, use to determine their premium, and there are potential biases in those as well.
We even found when we were doing in-house evaluation of an EHR vendor early alerting tool that the way they calculated performance metrics was basically retrospectively from a positive event up to a certain threshold. So 24 to 36 hours prior to an event, how did the system, what alerts did it generate? And that was how they determined the performance metrics. But that completely ignored the fact that clinicians have to use these alerts prospectively, looking forward. They don't know if there's a positive outcome on the other end of that alert. And those alerts might be generated much longer than 24 or 36 hours before a target event. So the actual firing rate and false alert rate of this diagnostic tool that we calculated was massively higher than what the vendor was publishing. And when our clinical teams took a look at that, they said there was no way that they could staff up to handle that type of alerting rate, given a 1 to 2% true positive in that alert stream.
All right, just one last question for you, and then we'll wrap it up. Do you know if there is any AI data set sharing between the UCs?
That is a question that I will leave to our CIO. I know that there is huge work in that direction, but I do not know what the status of that is. Certainly, there's the common de-identified data set, clinically de-identified data, which can be used for training. But when we talk about higher level data sets, including language models, I don't know if that's been published yet. Hossein, have you heard?
Yeah, I don't know that either. I was just going to talk about as you mentioned, the de-identified data set that I don't know exactly how the process of sharing across UCs work, but that's the only thing I can think of.
I think that's a great question to take back to each of our campuses, CIOs.
All right, that is a wrap. Thank you, Rob, and thank you, Hossein, for your presentation today. And thank you, everybody who attended. It was great to see such a nice group. I think we almost got to 50 at one point, which is a great turnout. Absolutely wonderful. And since these are the last sessions of the day, if I understand, if you're at UC Berkeley and driving back, please have safe travels, driving, flying, however you're going. And if you're not, may the rest of your workday be super productive.
Thank you all.
Thank you.
Bye, everybody.